Thank you, John. Today I have the privilege of speaking with Dr. Meena Seshamani, who was named just over 1 year ago today as Deputy Administrator and Director of the Center of Medicare for CMS. In this role, Meena leads the center's efforts in serving nearly 63 million people covered under Medicare, including those 65 and older, those people with disabilities, and those with end-stage renal disease that rely on Medicare coverage. She's an accomplished strategic leader who understands the complex health economics while maintaining a deep personal commitment to outstanding patient care. Her diverse background as a healthcare executive, health economist, physician, health policy expert give her a really unique lens into the healthcare issues that are important to all of us in this room. Prior to CMS, Dr. Seshamani most recently served as Vice President of Clinical Care Transformation at MedStar Health, a 10-hospital, 300-plus outpatient care site health system. She also brings decades of policy experience to her new role, including serving on the leadership of the Biden-Harris Transition HHS Agency Review Team, and has served as the Director of the Office of Health Reform at the U.S. Department of Health and Human Services. Please join me now in a warm welcome for Dr. Seshamani. Thank you so much. It's so nice to have you here in Boston, and being a true Bostonian, I can really welcome you to our city.
Thank you for having me.
I wanted to talk quickly, just touch sort of high level. Earlier in the year, you and other CMS leaders unveiled a new vision and agenda for the agency. I wanted to know, within those proposals, what you feel is going to be the most impactful and what really excites you about the future of Medicare.
Well, I think what will be the most impactful and what is most exciting is where we have been through a lot. That's an understatement for these past 2 years with the pandemic. And where there have been those opportunities for us to be able to innovate, to be able to drive what needed to be done to keep communities healthy and to really fight the pandemic, where there are those lessons learned for where we can take the healthcare ecosystem moving forward. And I think this comes to, you mentioned the Vision for Medicare that I published in January with our administrator, Brooks LaSure, and Director Fowler from the Innovation Center. Where we can really advance health equity, expand access to coverage and care, drive innovation toward high quality, whole person care, and be good stewards of our program. And to be able to do all of that, really galvanizing the momentum that the pandemic has enabled all of us to come together to really try to address the biggest crisis in public health of our time. I think that is an imperative for all of us engaged in caring for our populations moving forward.
For sure. I want to talk about health equity, and we'll get there. Maybe as just sort of a level set for our audience, would you mind sharing your approach to policy making when CMS may have limited authority to expand access, to innovate new payment models or new care delivery models? Can you talk about that?
Yeah, well, there are different levels to how these programs work. So first, there's statute. What does the statute say about what a program will do? That's maybe at like the 50,000-foot level. Then within that, then it comes to the regulations and the administrative authorities, where we're able to take what are the statutory authorities we're given to say, okay, this is how this is then going to be rolled out through our policies and our programs. Then you come to, that's maybe 25,000-foot level. Then you come to care playing out on the ground. So, we have our operations in the Medicare program. We pay almost $1 trillion in claims each year. We enroll providers, right? We do outreach and education, et cetera. But that's also where then you galvanize the entire ecosystem that's caring for people. And I know this from my prior roles, leading care transformation, caring for people right in front of me, where that last mile matters. And so where we have those opportunities to partner partner where we have statutory authority, we're able to put forward a regulation, get engaging to get feedback where there are opportunities, where there are barriers, and ways that we can improve things, to then being able to facilitate partnerships and engage with people on how that environment that we create with our policies then plays out in caring for population. So it's kind of all three of those levels.
So what are the challenges there? You mentioned opportunities, so what are some of the challenges that you face?
I mean, I think it's very important, and I think the pandemic really showed this. It's so important for us to think in a different way and think beyond our comfort zone sometimes, right? I mean, in my prior role, we engaged community health workers to go out in mobile vans to primarily African-American senior housing facilities in inner city Baltimore, because that was the way we were going to reach people in terms of being able to have trusted communicators and partners to be able to get people vaccinated. I think we all need to continue to think about, you know, different ways of doing things. Who can we bring together? And that means leveraging data, because now you're bringing together, say, community organizations and social services with more traditional healthcare organizations. How do you enable that communication? How do you get people to work, you know, in more team-based environments? But I think the challenge is the opportunity there. And I really think that's where the work is moving forward. But if we think about things just in the way that things were always done, then you're never going to achieve that. It really is about saying, okay, where is that next step? And where is that next level? And realizing that no one person, no one program, no one organization can do it alone. Medicare is large. $1 trillion in claims, 63 million people. Certainly, there is a huge market power, you know, messaging opportunity where when something is done in Medicare, it has ripple effects through the ecosystem. But Medicare can't do it alone. It really does come to providers and payers and employers and innovators and community organizations and family caregivers, for example. I mean, there are so many aspects that are involved in the experiences that touch a person and their health, and being able to keep all of that in mind and try to galvanize all that is both the challenge and the opportunity.
No, absolutely. I was talking earlier to someone who was saying those same exact words, a large employer. I want to talk a little bit about, in May of this past year, you authored a great piece in Health Affairs, and it was titled Medicare and Telehealth, Delivering on Innovation's Promise for Equity, Quality, Access, and Sustainability. And it was really a great piece, and I would say that you might have thrown the proverbial gauntlet to those of us health tech leaders. Let me quote you, if I may. Healthcare leaders must ensure that these technologies and advances access while also addressing existing disparities and not exacerbating or causing further harm, considerations of broadband internet access, cultural and linguistic appropriateness of service, and familiarity and comfort with technology among the diverse population of people with Medicare should guide the effort of development, dissemination, evaluation, and innovations in health. And let me first just say, yes, challenge accepted. We truly share in this goal of advancing health equity. I mean, certainly our mission at Teladoc Health is to help all people everywhere achieve their healthiest lives. So talk to us about what you believe the role of telehealth is in executing on that mission.
Yeah, and I will start with where did that thought come from, right? That was in that piece. And there was an HHS report that was done recently looking at telehealth usage by people with Medicare in 2020. And it found that there was a 63-fold increase in telehealth utilization, you know, because of the waivers, et cetera, that were provided during, at that point during the pandemic. However, telehealth utilization among people with Medicare who are Black or living in rural areas was less than their white and urban counterparts. And that is something we need to think about. Why is that, right? And so that's to say, again, that when we think about these technologies, we need to think about them where they can expand access, where they can advance equity and not increase disparities. There are absolutely opportunities for these innovations, telehealth and other care delivery innovations, to be able to address disparities. I think behavioral health is a good example where, in that same report, the largest increase in telehealth utilization was in behavioral health. And I think we know how successful behavioral health has been in terms of increasing access, and behavioral health is deeply tied with equity. And so, thanks to congressional action, this comes back to what I was saying about statute, administrative authority, and then care on the ground. Following congressional action, we made telehealth payments permanent for behavioral health in the physician fee schedule, including audio only, to get at issues of broadband access. We just proposed in the outpatient prospective payment system to enable telehealth to be provided for behavioral health by outpatient hospital departments to patients at home. And again, this is where the engagement with the communities is so important, because we heard, particularly in rural and underserved areas, a lot of times the critical access hospital are the healthcare providers in that area. So when you're enabling, a clinician office to be able to do telehealth by behavioral health, well, what if someone is living where there isn't a clinician's office, but there's a hospital? So we've proposed that the hospital can do, outpatient hospital department can do telebehavioral health to someone who's not admitted to the hospital, but someone who's at home. Again, it's out for comment now. But again, thinking about where there are those opportunities that innovations can expand access to try to get at some of the disparities that have been present in our country.
So you mentioned something in there that I want to just drill down on. You mentioned using, what lens do you use to actually look at the value of virtual care or telemedicine?
Yeah, I think it comes back to what the piece that I wrote that you were referencing. We have our vision for Medicare and for CMS overall. We want to be able to advance equity. And just to take a step back, how do we define equity? Mm-hmm. So equity is everyone having a fair and just opportunity to achieve their optimal health, regardless of their race, ethnicity, geography, income level, gender identity, sexual orientation, language, culture, right? Everyone should have that fair and just opportunity to achieve their optimal health. And to do that, we have to be able to address health disparity. We have to be able to address disparities. We have to be able to address health-related social needs. And so where can telehealth and other innovations be able to drive forward there? And I think the example of what we're proposing with the outpatient telebehavioral health is an example where we want to be able to leverage that to be able to have access to this care. Then thinking about innovation and about how do we drive that whole person care, that high quality whole person care, and where can telehealth enable better communication in a team-based approach, being able to see people as opposed to here comes someone for a specific clinic episode with this, ICD-10 code, and I'm going to bill for this E&M code. People exist outside of that, 15, 30-minute office visit or outside that hospitalization. And there are significant opportunities for innovation to expand our aperture of how we view people and to view them as people who are in their houses, are in their communities, and where we can leverage data, where we can leverage care management technologies to be able to bridge across social services and healthcare services and across all of those different venues in which someone might touch a person in our program. And then I think the third big bucket is around sustainability. Right? We have to be good fiscal stewards of our program. And so this is also where I challenged in the piece that telehealth and other innovations should not just be, well, instead of doing this siloed office visit in person, we're now going to do the siloed office visit virtually, right? I mean, there is an opportunity for these innovations to fundamentally change the way that we are caring for people so that we are providing better care, we are spending money in a smarter way, where you're moving care upstream. So you're addressing things earlier on so people don't become sick. They don't end up in the hospital, and that leads to smarter spending and healthier populations. It reminds me, work that I did before where A woman kept getting readmitted to the hospital with chronic obstructive pulmonary disease like 17 times. We assigned a community health worker to her. Community health worker goes out to the house. Her electricity kept getting shut off, and so her nebulizer wasn't working. All those hospitalizations, as soon as that was fixed, guess what? She didn't come back to the hospital and she was healthier. And there are all sorts of examples like that where innovation can really fundamentally change the way that we're caring for people so that we are driving towards those strategic pillars.
That's great. We have 7 million Medicare Advantage members accessing telehealth today, and over 200,000 Medicare members who are active daily users of our remote patient monitoring chronic care programs. And we know from HHS that nearly 30% of Medicare populations have diabetes and many other cardiometabolic diseases and comorbidities. So there's a disproportionate, and we also know that there's a disproportionate problem with impacting the communities of color. And so what we see is a major challenge. I'm trying to sort out whether you could talk a little bit about reducing those disparities and what you're seeing as sort of those opportunities for us to use virtual care and telemedicine.
Yeah, I think this comes back to how do we see people as people and care for them more holistically. Mm-hmm. So to take the example of diabetes, in my prior role, I led our diabetes management program. So for people who had hemoglobin A1C greater than 9, what could we do to help them to, bring their diabetes under better control? And looking at readmissions to the hospital. And our diabetics who tended to be readmitted to the hospital frequently, who had hemoglobin A1C greater than 9, I think 2/3 of them had a behavioral health diagnosis as well. Mm-hmm. So you can give all the guidance about healthy eating and exercise and teaching people how to inject the insulin, and if they can't get out of bed in the morning because of their depression, mm-hmm. You're not going to be able to really help them. And so I think there are huge opportunities for us to be able to leverage more team-based approaches to care, to reach people in other settings than an episodic, office visit, so that you can address the myriad of things that do impact a person as a person, so that you can help them get and stay healthy.
So what needs to change in terms of policy to achieve that?
So I think being able to create an environment that supports these holistic models mm-hmm. of care. So as an example, in the physician fee schedule that we recently proposed, we're making some of the biggest changes to the Medicare Shared Savings Program, which is the largest value-based care program. It has accountable care organizations, so groups of providers who come together to take accountability for a population of patients for higher quality care and spending money in a smarter way. If you keep people healthy, you keep them out of the hospital, keep them out, from being readmitted, et cetera, while achieving quality standards. In this proposed rule, we are providing upfront investment dollars for smaller providers, those in rural and underserved areas. Because what we heard is, these models work. There has been tremendous savings to the Medicare program, high quality scores, but smaller providers, those in rural and underserved areas, don't necessarily have the upfront capital to be able to invest in the infrastructure needed, data, technology, teams, to be able to engage in these models. The Innovation Center tested a model to provide these upfront payments. It was very successful, so we said, let's scale this in the Medicare Shared Savings Program, which cares for 11 million beneficiaries. So small providers, rural underserved areas can get upfront investment to be able to join these holistic models. Joining these holistic models means team-based approaches to care, where you're trying to keep people healthy, keep them out of the hospital. So that's an example of the foundation that you can create for this kind of work to happen. We also proposed in this physician fee schedule to expand access to behavioral health providers. So paying clinical psychologists and social workers for providing behavioral health during a primary care visit. Right? So where are there those opportunities where on the policy side, We can encourage these more integrated care models where you're focused on health and keeping people healthy rather than just treating them, when they get sick. And I think that's a lot of work, again, that we want to do in partnership with those who are caring for our patients, those who are innovating in newer technologies to be able to support the providers who are caring for patients. And again, being able to think more broadly. We're soliciting comment on community health workers and what role can they play in that team-based approach to care.
You mentioned the Innovation Center. I want to ask you, could you talk about how the Innovation Center works with the Center of Medicare?
Yeah, absolutely. So we released, I think it was almost a year ago, back in August of last year, the CMS leadership released a health affairs piece on innovation at CMS. And importantly, it included all of our leadership because it's so important that all of us are aligned. The Innovation Center is the Innovation Center. It's the R&D arm of the Medicare program and the Medicaid program. So where there are things that we want to test in the Medicare program, the Innovation Center can test. If it's successful, we can think about scaling it in the Medicare program. If it's not successful, then we have learned. The example I gave of this advanced investment payment that's in our proposed rule, that's an example of the alignment and the work we're doing, because that was a test that was done in the Innovation Center that was found to be successful. And so we have scaled it into one of the Medicare programs. So, Liz and I, we work very closely together, and we say it's like the Innovation Center is the ice cutter, and then Medicare is the aircraft carrier kind of coming behind. So, the Innovation Center will test things out, and then we see where we can really leverage it. Again, because as I mentioned, Medicare has huge scope and breadth and can really be a mover for the healthcare ecosystem.
So we are surrounded by representatives of health plans, providers. Talk to me a little bit about how expectations from plans and providers and delivery systems change moving forward as the shifting policy environment.
Well, what I would say is, again, we really want to drive towards our true north, which are those strategic pillars around equity, around access, innovation, stewardship. And to do so in a way that's data-driven, that's being transparent, that's promoting competition for the market to work better, and really putting the 63 million people who rely on our services at the center of everything that we do. What that means is we all have to work together. We need to engage. I need to hear your ideas of what we can work on together. I want to talk with you about, okay, here's where we want to go. What can you guys do, right? It really is a team effort across payers, providers, innovators, patients, and beneficiaries. We're also engaging with the people who we're serving. What is it that they want, right? With employers, with states, really, there are so many who touch the people in our programs. And increasingly, there's such an interconnectedness of all of the parts of our society, our healthcare system, our economy. And so what I would say is, here are our collective goals, and let's link arms and do it.
Love it. I love it. One final question. You had mentioned those sort of three levels, and one was community. And we haven't talked about your role as a physician in that context and actually delivering care. So how has being a physician shaped your views, your perspectives, your policy ideas and innovation ideas because you've experienced it really in the communities and delivering care?
Oh, I mean, it absolutely has, because I have personal examples, right, of people that I've taken care of. There was a gentleman so I'm an ear, nose, and throat surgeon, and I remember when I was a resident, there was a gentleman who came in with a huge throat cancer, and he was coming in for surgery, and I was reading the clinic notes, beforehand. At that point, it was still handwritten, and I saw, it said, social history, drinks 33 beers a day. And I'm looking at it, I'm like, is that someone wrote 3 twice, right? So I went and I asked him, sir, it said you drink 33 beers a day. He said, yes, I drink 33 beers a day. And he went into surgery. It was this huge removal of the tumor, free flap reconstruction, his nutrition was shot. I mean, drinking 33 beers a day, he had to be detoxed, right? After the surgery, was in the ICU, and his wound completely dehisced. It was this complex packing. He didn't have like the family support, so he's sitting here in the hospital. We're trying to figure out, okay, how are we gonna get him to a nursing facility? And that's just a perfect example of where we need to think about people as people. There was more than just that tumor that needed to be removed. There was an entire social fabric, or maybe lack thereof, that this gentleman was living in, that really that's how we're gonna care for people, is by thinking about people as people again. So, I mean, I have tons of stories of, I can go on, but I think, more importantly, it's that, when we're thinking about policies, like I am seeing the people that I have cared for and how what we're doing now can help them, right? Like now, we're expanding access for substance use disorder and opioid use disorder. That could have helped that patient that I had, right? So I think absolutely, my experience as a physician really does impact at a very personal level, how I view what it means to keep the people that we serve at the center of everything that we do.
Absolutely. That's a great example. And I think it's also an example of how both physical and mental care play out in that holistic view and caring for those members. Well, thank you so much. It was lovely to have you. So great round of applause. I really appreciate it.